again my colleague was suggesting a topic of lymphedema, which may not be much commonly coming across in some parts of India. Some parts it's very much more common. We were working, me and Professor Unitan sir was working together. I worked nearly 10 years. He might have worked more than that in government college, Alappuzha, where it is very, very rampant. At that time it was rampant, and I was a junior surgeon. I was called upon to amputate, because that's the only go in some cases where you get a nidus of actually the bacterial flora inside with pus and pockets, which cannot be, like you get an infection of a very big keloid. That is a pocket, you cannot get rid of it by just doing an incision drainage or extreme. So I was amputating almost. I remember one lady, very, very much known to me, having something like a stem of a coconut tree, isn't it? That much big leg, isn't it? Since we are rampant in the Chertale as well as the Alapi district because of the pistia plants there and the Butcher area, the Brugia Malay being the causative agent of this lymphedema. So there it was very rampant, but elsewhere lymphedema you might not have seen. But there is a very systematic classification of lymphedema. By the way, I think I should highlight initially to open the topic as what is a lymphedema and what way it is differing from other edema, conventional edema. There is a very basic teaching saying that lymphedema will not pit or pressure, whereas inflammatory edema usually used to pit. And one more exception is mixed edema, which also won't pit to pressure. But this pitting is very subjective, and pitting is also stage-wise. Even in lymphedema, you get pitting at the very first stages. So we are going to have the categorization of that in a, like a theoretical presentation. You will be knowing more about it, but maybe my slides are having little more to the postgraduate level, which I may not highlight or I may not read in detail, just to show that only. So we start with the first. There's a definition which is keenly stressed in Bailey, saying that it's actually difficult to mug up, but then I will just read: abnormal limb swelling caused by the accumulation of increased amounts of high protein interstitial fluid. That ICF is an accepted short form now, interstitial fluid. I would like to ask for the undergraduates, what is your concept of interstitial fluid? What's the other synonym? The synonym is extracellular fluid. Extracellular fluid. What's the difference between lymphatic fluid and the extracellular fluid? Can anybody volunteer? Extracellular fluid and lymphatic fluid. Whatever is not inside the cell or whatever is not intravascular is extracellular fluid. That is caused by, if I ask a very tricky question to stress that, how will you get the drug reaching our body when we take an IM injection and an IV injection? IV is very speedy, directly injected into the bloodstream. But if you inject it into the muscle, what is the source of reaching blood? Have you ever thought of that? Then it's a very, concept provoking question. That's it. So when we inject certain substance into the extracellular fluid, what does that mean? Extracellular fluid means it is under a capillary pressure from the intravascular. A capillary pressure, pre-capillary sphincter is there, a post-capillary sphincter is there, and from there is a filtration. The fluid reaches there, but it is rich in nutrients as well as oxygen. That's how the tissues get it. We all feel that it is through the capillary directly goes to, no. From there is a filtration pressure, and the filtration pressure compels the fluid to bathe the cell's surface, and from there is a diffusion of nutrients as well as oxygen. And the nutrition free and the oxygen free component of the extracellular fluid, that is what is named as the ICF, interstitial fluid, devoid of or denuded of nutrients as well as oxygen, filtered out of the capillary pressure. That I explained, because that concept, if it is there, then we can know how when an extracellular drug reaching there is reaching also through the lymphatics, then mainly through the lymphatics as well as some back pressure diffusion through the filters if at all minimal. That's how it reaches finally from the lymphatics to the bloodstream. That's why it requires half to 1 hour, sometimes at least after an IM, when we compare it to the direct injection into the bloodstream. So the definition says that secondary to defective lymphatic death, the reason for the interstitial fluid being stagnant is because of the defective lymphatic drainage. That is the core content of today's topic, how it manifests as the edema. Now this is of course for undergraduates, you may find it little difficult to know, but if you know this is only just to read out recurrent lymphangitis causes obliteration of lymph cells leading to dermal lymphatic backflow, and it is a dermal lymphatics which is manifesting in the form of hypertrophy and proliferation of the tissues, finally getting grotesque appearance secondary to infection, ulceration, cracking, etc. So dermatic lymphatic flow will be going to inducing retrograde obliteration or dieback of lymphatics, dealing on the edema, initially pitting, and then you get infection supervening, you get recurrent cellulitis, thickening of the skin, and then you get accumulation of proteins, growth factor, glycosaminoglycans. That word you just note it down. Glycosaminoglycans. These are all trophic factors which will be just exacerbating the rapidity with which the subcutaneous dermal tissues are proliferating. So trophic also. And trophic means nutrient-like, and that's what I mean. Trophic, not tropical or trophic. Trophic also is also used for gravitational trauma-related, denervated ulcers, etc. Now, activation of collagens and keratinocytes are taking place, and you get protein rich in lymphadematous tissue. There is enough protein in the lymphadematous tissue, and that leads to protein rich lymphadematous tissue formation, deposition of ground substance, and subdermal fibrosis. Wherever you are thinking of fibrosis, you should think of lymphocytes modifying into macrophages and macrophages laying collagen, etc. So there is a fibrosis. Dermal thickening and dermal proliferation leads to, as I said, cracks, ulceration, abscess formation, and stout leg with grotesque appearance and unbearable weight of the limbs. I'm going to show you some pictures also. Now we can classify it like any hypertension or any other region. This classification is a very fond classification for all of us, irrespective of the causes of the pathology, where you get a primary and a secondary. Primary is otherwise named as idiopathic. But usually primary may not be the dominant lymphedema when you take the total statistics of the lymphedema. So what you get is, more common is secondary lymphedema than primary lymphedema. Because secondary is, as the term is self-explanatory, it is always occurred due to non-reason. So primary, there are various entities, we will come to that. Secondary, again with underlying non-causes. Now, I've just divided it, etiological classification lymphedema, we have 3 entities. One is named as congenital itself. That will be affecting the individual before, is in the infant phase and the next year. So up to 2 years it is named as congenital, and that is what is commonly taught to us as Milroy's disease. Nowadays Milroy is widely being used because two great persons initially described it. Then you get up to the 25 years, from 2 years onwards, what is named as the lymphedema precox, second entity of the primary lymphedema. And the third entity is that is named as Meeks disease. Second entity is named up to 25 years. If you get a congenital reason of lymphedema, then you name it as Meeks disease. And after 25, what you get without any known causes as primary lymphedema is tarda, lymphedema tarda. I just want to stress again, the primary lymphatic anomaly is better put in a single term. It is due to a dysplasia of the lymphatic system. You all know the meaning of dysplasia. Dysplasia may be constituted by total absence of development, which is named as anaplasia. You get a hyperplasia, means uncontrolled replication and development, and you get a hypoplasia also, means underdevelopment. So dysplasia is a generic term describing total absence as anaplasia or hyperplasia or hypoplasia. All those may add to the primary lymphadematous derangement for primary lymphedema of the lymphatic channels, not lymph nodes. Whereas secondary lymph nodes may affect the lymphatic channel or the lymph node. That is the difference between secondary and primary. Now, these are the known causes. I am not spending much time on that. You can all read it. There are secondary causes induced like parasitic infestation like filarias, which I mentioned rightly. Filarias is commonly in our state, it is due to Brugia malei infestation through common development of mosquitoes from Fistia plants. And you get fungal infections like Tinea pedis, exposure to foreign body materials like silicon particles, etc. Primary lymphatic malignancy, metastatic spread to lymph nodes as in case of secondary nodes, radiotherapy to the region, surgical excision of lymph nodes as in case of block dissection. Following that, we get a block dissection of the axilla, conventionally known and notorious to cause lymphedema of the upper lip as in case of breast carcinoma. This treatment, surgical excision, trauma to that area, superficial thrombophlebitis, deep venous DVT, etc. are the other causes. DVT per se can cause swollen limb with edema, but it can also cause secondary lymphedema. Now, secondary lymphedema, this is another classification where you get clinically, they can be classed as up to 2, it is non-pitting. Up to 2 it is pitting, means subclinical where you get only anomalies detected, may not be clinically manifestable. In level 1, in lymphedema 1, what you get clinical category 1 is a reversible, like elevation can reduce the edematous status of the limb, or you get pitting, and 2 onwards you get edema which is non-pitting, that is does not significantly reduce upon elevation, and level 3 edema is associated with irreversible skin changes and fibrosis papillae. You get globular swelling like a grotesque pebble laid limb, etc. We will come to the pictures of that just to demonstrate. Now, the risk factors are classed here. In upper limb, it is surgery, radiotherapy, advanced cancer, obesity, hypertension, chronic skin disorders, air travel, congenital predisposition, etc. Now, the symptomatology. You get a list of symptoms like pain, dull aching pain, that is described, something like cramps cramp symptomatology overlapping. You get burning, bursting sensations, you get sensitivity to heat, pins and needles, flakiness, weeping, excoriation, breakdown, etc. Restricted mobility, obesity, muscle wasting, athlete's foot, acute infective episodes, squared toes. I will show the pictures because the toes are occupying something like square shape as you get grotesque edema, buffalo hump of the dorsum of foot, stemmer sign. I'll show the picture and explain when I come to it. Now, here is a description. Characteristically, it involves the foot initially pitting edema and on limb elevation. A good picture is there. It's yielding to the thumb. Now, buffalo hump or the dorsum of the foot, you get loss of normal perimalleolar shape resulting in a tree trunk pattern, especially in the angle of the foot. You get loss of obliteration of the depressions between the consistent with the malleolus, and you get a tree trunk pattern. You get square toes as is shown in the other picture. The shape, I wonder whether it is square or not, but it is described as square because all the borders, proximal, distal and the lateral and medial is obliterated. And you get the stemmer sign where you try to pinch the dorsum of the toes or skin. You are unable to pinch it, and that is aptly described by stemmer as a stemmer sign. This is another appearance. Probably I might have seen much more worse or long-standing limp during my period of service at Alapi, because you get the entire thing like elevated, walks or the gravel-like appearance of the surface of the limb, affecting even the entire leg. This is another appearance where you get beginning of the papillomatous lesions at various sites of unilateral limb. On the dorsum of the foot it starts. Now, here is a very good description of the causes of swollen limb. You get lymphedema as is the topic of discussion. You may get the swollen limb due to venous causes like DVT, CVI. You get arterial causes like AV malformations, aneurysms, and you have an array of non-lymphatic, non-vascular, systemic as well as local. My professor, it was his fourth statement that whenever you get, Professor K.V. Roy sir used to teach us in first year level onwards as a postgraduate, whenever you get bilaterality of the edema, always think of systemic causes. You get unilaterality, think of local causes or localized venous, arterial and such things. That is a doctrine, so to say my reverence to my great professor. Because if you get unilateral lymphedema, think of surgeon's field especially. If you get bilateral lymphedema, think of physicians or other super specialty related or organ related causes. So you get systemic, cardiac, hepatic, renal, hypoproteinemia, drugs, allergic, obesity, etc. belonging to systemic. Local we get again causes like trauma, hematoma, tumors, bony soft tissue, ruptured Baker's cyst, myositis. I have had a case of usually when you open the, it was not just, it was actually posted for fasciotomy of the leg. When you opened up, it was all something like, orange peel, pulpified appearance. It was due to a Moran-Baker's cyst bursting and gravitating to the leg, presenting as a swollen limb of that. We thought fasciotomy will do, but we opened it up to the back of the knee, and the cause was burst open Moran-Baker's cyst. So that all may be there. Now, primary lymphedema is, of course, an inherited anomaly of congenital lymphatic dysplasia, as I rightly put it. And then, so it may be hypoplasia or hyperplasia. Both are actually functionally inert. Functionally, it won't be as good as the tone of the normal lymphatic vessels. So it may be underdeveloped or may be overdeveloped but inefficient, or may not develop it as in case of anaplasia. Common in lower limb than the upper limb. Now we can classify also as I mentioned rightly, depending upon the age of onset. Before 2 years it is named congenital per se. It is named as the Milroy's disease or the Noni-Milroy's disease. Precox is named as the Meeks or the Letessier-Meeks disease up to the age of 35 years. And then beyond 35 years, you get primary lymphedema tarda. 35 years. Anything, sir? You want to ask something, sir? No. No, this is of course a little more extensive just for the undergraduate sake, but just see there is a classification of congenital hyperplasia, distal obliteration, proximal obliteration with strategies of that edema being put to compartmentalization. That's all. We may not bother, may not mug it up, etc. But there is a classification like that, fitting into specific entities. Now this is a beautiful picture to show what is a lymphangiogram. Lymphangiogram in our time when I was a PG used to be taught as the web space being injected with a dye and be cannulated with a micro probe like Salis method, tube, etc. being used and probe into that. But it is said it's almost getting obsolete because very difficult to perform. The pressure may not be sufficient to delineate it. Like we do a pilonidal sinus. Nowadays nobody injects methylene blue, isn't it? Because methylene blue may be only just tracking, just showing only the unobliterated part. The obliterated part may be the culprit remaining, so it cannot delineate. You have to solve your naked eye inspection while you operate. So like that, this is a beautiful picture. On the other side, the lymphatics are well seen. This is actually just a narrow lane of the, if at all, remnant of the lymphatics. Secondary lymphedema, of course, as I said, most common form of lymphedema, non-primary causes induced. Etiology as detailed and listed under our causes. These are the causes. Again, I am not reading out to save time, but you have causes like trauma, only mainstem I am saying, trauma and tissue damage, malignant diseases, venous diseases, infection, inflammation, endocrine disease, immobility and dependency, and factitious self-harm, self-induced harms. So these are all the causes under which you get a lot of this thing. Don't be very panicky by seeing that big chart having rich tentacles. But no, you can see it in any book if you want. Before going for exam, maybe you can revise it. Like books like SRB, you may get instead of 20, maybe 25 causes. But first of all read Das, first of all read Bailey, and then you go to that. Otherwise you will be confused. You will be writing the 22nd cause as the first cause. That is the main criticism of our side. I know him, he's a colleague of me, very good friend. But because then the list is enlarged, the undergraduates gets confused. If I ask swellings moving with the deglutition on deglutition, the answer from that sort of learning is, they may say that subhyoid bursitis. I haven't ever seen a subhyoid burst. Of the 4 causes, this priority is always priority. Common things are always common, as my great professor used to highlight us always. Now, secondary lymphedema, most common form of lymphedema, known primary cause or induced, etiology as detailed. Is it going back? I think. Okay. That is the picture. This is another patient in her 6th decade, present with rapid onset of lymphedema on the right leg. On further investigation, she was found to have locally advanced bladder carcinoma. Note that unlike most cases of lymphedema, the swelling is greater proximally than this. That's why it is named as liver. It's an advanced case of bladder carcinoma, but constituted by proximal lymphedema. That's why that picture is. Now this is the grotesque appearance of something like the elephant foot, has to say, isn't it? So, and the poor individual is destined to walk upon that. I think when I was an UG, even that time onwards, it is prevalent in Bailey and now, isn't it? As a picture. Now, investigations of lymphedema, we mentioned routine hematology, lymphangiography, but this almost now it's being taken away by isotope lymphangiography, where we utilize technetium scan, technetium protein, labeled protein colloid particles as the means of doing the scintigraphy, lymphoscintigraphy. Now CT mid-calf, CT will be useful to assess the tissue of the lymphedema as to plan the management. That is the main use of it, the nature of it. So you get honeycomb appearance, you get venous edema, well delineated, lipedema, increased subcutaneous fat, etc. are better assessed by a local CT of the region. Useful to rule out primary pelvic abdominal masses also in case of the CT. Now we can utilize magnetic resonance in selected cases again to assess the soft tissue as well as the gravity of the soft tissue derangement. Ultrasound will be, of course, helpful to delineate between venous and lymphatics. Lymphofluoroscopies are also listed under that. Pathological examination of lymph node sampling with FNAC, core biopsy, focal excision biopsy of suspicious areas. Suppose if you get some area being whether it's a lymphangiosarcoma, etc., regional changes, because of you are in a dilemma to know whether there is malignant changes taking place there, etc. FNAC is the first cytological help. Then you can have biopsy of that area like an excision or an incision. Lymph volume measurement also will be helpful. Management of lymphedema, initial education. Usually, I must stress that here is one scenario where surgery is not the first go or is not the mainstay of treatment. Usually, majority are treated for a significant period of their life by conservative line of management. So we should know what are the conservative measures available. We should have the history to be probed into, as I said in jaundice discussion. Here is a scenario where you get good points to class it under primary or secondary based upon the history. Past treatment history should be probed into family history, obesity, past history of complications, if any, following treatment, assessment of symptoms, assessment of social circumstances, special needs, etc. to get some points related to mobility, housing, education, work, footwear, clothing, compression garments, all those you have to ask. Pain control measures required, compliance to therapy and self-dependency. These are the things to be probed into. Conservative measures include, mainstay of treatment is actually relief of pain. You have to adopt any sort of pain relieving measures, including from paracetamol onwards, tramadol onwards, and physical measures of pain relief even can be balms, those things soothing temporarily may be good. Now counter irritants may be good, provide the skin permits it, skin texture and nature permits it, etc. And regional blocks, especially in excruciating pain. Now, control of swelling can be attained by decongestive lymphedema therapy, like intensive care, face skin care, manual lymphatic drainage. So you should teach the patient by physiotherapy, elevation, temporary massage, by active as well as passive measures. Patients themselves can do it to a significant extent. Multi-layer lymphedema bandaging and compression garments tailored to the patient's requirement and stature of the limb has to be. Usually, many a times it is useful to have tailored garments than ready-made. Then you have exercises, you have maintenance phase also. Now, here is a word about the selected cases of surgical aspects. When I was a postgraduate, I was astonished by seeing a presentation of one of my great professors. The surgery is known as Tanjavur surgery. Now, Tamil Nadu. As a great surgeon, my professor, Professor Roy sir, was very fond of Kusheri, Giles and Mozart textbook that time. So I bought a book that time. I still with reverence remember my professor, because it was containing not only current therapeutics of surgery and clinical measures, but it also includes every chapter having the way ahead at the bottom of it, about an update of the recent advance. So in that book, the very same name surgeon, from today morning when I was traveling with Unnitan, we were discussing about Jamal sir, and Sir Unnitan was giving me an impression. I was not aware that he is a Keralite. He is a Keralite from Kayangulam, he said this. So his name is, that time edition onwards, is there in Tanjavur surgery, Dr. Jamal Yal. Yetal is the writing, but he pronounced it as Yal. T is silent. So that much great international known surgeon. So I had a presentation as a PG to be watched, and then I saw a grotesque limb of a young lady, grotesque limb of a middle-aged lady being shaven by debulking surgery, and that time he has popularized nodovenous anastomosis, lymphatic drainage by, and it is such a beautiful limb that it was mimicking like a girl. But now recent editions say that other procedures like Charles procedure, etc., are mainly debulking but cosmetically very poor. I don't know how sir has attained that time that great result. So I cannot start any surgical treatment mention unless I mention the great name of Jamal sir, Tanjavur. We have to be proud of being in Tamil Nadu and Kerala, being a surgeon from Kerala but worked in Tanjavur and popularized the name as Tanjavur surgery. So that is there. So we have a list, an array of options. We have bypass procedures to tackle the dysplastic, underdeveloped or overdeveloped but functionally underdeveloped lymphatics, or no development, etc., by a bypass. So we have, these are the options of bypass procedures. You can have direct lymphatic bypass in segmental proximal hypoplasia if it is confined to segmental part alone. You have other indirect measures like omental pedicle, Gillis skin bridge operation, ileal mucosal pouch. That much details undergraduates may not require, but these are all the options I need to mention. Now you have microlymphatic anastomotic procedures, which was popularized by Professor Jamal at that time. Nodovenous anastomosis. Node is hemisected. A lymph node is hemisected, and the lymph node matrix, central part core is decored, and it is sutured as if something like is engulfing a vein. That is nodovenous anastomosis. So from there, the drainage is easily going to the blood. So nodovenous, Nilubovics, lymphatico-venous anastomosis, lymphatico-lymphatic. And I was a postgraduate, I used to remember that name, O'Brien's operation. The O'Brien's operation is described as a lymphatico-lymphatic, actually microscopic surgery, like microneuronal surgery or microvascular surgery, or microlymphatic surgery. And that was popularized by the Westerner O'Brien's. Now we have cosmetic debulking like liposuction onwards, and we have limb reduction procedures. Initial one was strung, where you get excision and primary closure. Homans, where you get excision of bulk tissue with mobilization of skin edges and primary closure. You get a Swiss roll operation. When I was on UG, that time onwards I am hearing this, something like a Swiss roll, where you cut The got a skin, open it, debulk the entire subcutaneous tissue, distorted, then you get a peeling off of the epidermis. Then the other flap skin peel is cut off, and then it is rolled upon itself, the dermal part, after debriding the epidermis. You get lymphatics of the dermal, subdermal lymphatics, other than the epidermis, taking out the lymphatics. That's the very purpose. I will show the picture. That is named as Swiss roll operation, or Thompson, like a Swiss roll cake. It is bent upon itself. And there is a popular Charles procedure where you get an excision followed by a graft. The main comment about Thompson's procedure, Charles procedure, is that cosmetically you debulk the limb, but limb is like an wooden bony part with only few subcutaneous tissue remaining and a grafted limb. So the appearance is not at all acceptable to the patient. That is the main reason. Tanjavur procedure, as I rightly said, done after Professor Jamal sir. Now, these are pictures to show my undergraduates may be curious. They may be at least curious about the Swiss roll cake than the Swiss roll operation. But the Swiss roll is beautifully shown there, the extreme end, where you get an incision, skin is removed, then you make a pedicled skin flap with the subcutaneous tissue. That is rolled upon itself, and the other flap is mobilized little as to get this much. I think this is Charles procedure, where you get an excision of the chunk of tissue of major cosmetically deranged tissue, followed by closure with flaps mobilized. Sorry, that picture shows the Charles procedure where it is shaven out totally, like a degloving injury happening, and then this bone and minimal subcutaneous tissue is patched with skin grafts. That is a cosmetically restored, that much appearing when you compare to other cosmetic procedures. Now, to end, as a take-home message, you should feel that it is such a grotesque limb. I mentioned in my early tenure, after my MS, we had no other resort other than amputations alone. But still, where there is a will, there is a way. And things are all not lost. We have the micro lymphatic surgery possible now. We have the excision procedures possible now. All those combined, such Herculean tasks are possible by this young gentleman. Like that, we should think of the management of the lymphedema. Primary, not secondary, primary at least, is where there is a corrective measure possible before it goes to derangements of complications and its sequelae. We should think of cosmetic appearance improving, debulking, as well as microsurgical procedures to tackle this malady since long. But secondary, definitely we have limitations. Thank you all for your patient listening. Would like to get questions from my younger ones, undergraduates, if there is any query regarding basic concepts at least.
Any questions?
So call it a day. I enjoyed the session here. Thank you all very much for your patient listening.